This video, I want to discuss the use of insulin therapy. Now, that's a big, potentially complicated topic to cover. So that rather than talking about specific brands of insulins and the specific types, I guess I'm talking a little more conceptually and how to think about, you know, how to use them, what sort of thoughts are important, rather than kind of getting into the small details of it. So insulin is something you have to use when you're treating a type 1 diabetic, or somebody who is otherwise deficient of insulin. They cannot make their own insulin. And so insulin's main job is to help move sugar from your blood into your cells. So whenever we're doing, let's say this is a type 1 diabetic and they're newly diagnosed and we have to start using insulin, what does that look like? Well, we try as best as we can to mimic what your body should be doing. And you should be, normally if we could sort of watch what your pancreas was doing, we would see that you're always making a little bit of insulin in the background. That's what we call a basal insulin production. And then when we eat something, in particular something with carbohydrates, we make a surge of insulin. And that's called a bolus, or a spike of insulin, you might say. So there, a lot of times we'll start with something called MDI, multiple daily injections of insulin. And a typical pattern would be using two separate types of insulin, one to cover the background and one to cover the small spikes that are necessary. So like I mentioned, there's all sorts of different insulins out there. The main things that are different about them is what is their time scope of how long they work, their action profile. So the basal insulins, most of them are once a day medicine. So you inject it, and whatever you inject, it slowly over the course of 24 hours gives you a stable and ongoing effect, and kind of gives you that baseline. So somebody might take one shot of a basal insulin. This would be something like Lantus or Tresiba or Toujeo. Those are some common ones right now. And then you would get a separate insulin that is the short-acting insulin, one that his action is onset within like 15 to 30 minutes. It's working, and then it's out of the system within 2 to 3 hours. And that would be insulins like Humalog, Novolog, and different variations of those. The older insulins that are out there, NPH or N and regular or R, really try to avoid those these days. They're still used sometimes when insurance coverage is a problem. It's not as much of a problem as it used to be, but they're just not as sharp. They don't have those profiles that work, that match those things quite as well. So I'm not going to talk about too much about those, just because they're fortunately things we don't have to use as much. So an MDI insulin regimen would be one shot of the basal insulin, and then you'd have a plan to, every time you eat something, you're going to take a shot of the short-acting insulin. And one of the important things in this regard is the timing of it. You have to inject about 15 minutes before you're going to take your first bite of food, the short-acting insulin. And that's because it takes about 15 minutes to work its way underneath the skin and get into the bloodstream. So that's something that can be kind of a scary thing to do, to inject that insulin and then wait, because the fear of, okay, I'm going to have a low blood sugar before I even start eating. That certainly is something that is valid, but with experience, people, are confident and find that that doesn't happen. So a lot of times, how do you do the insulin with food, which is prandial insulin? That's really the most challenging part of all, because we don't do things the same way. There's so many different variables. So a basic way to do it is to say we're just going to estimate that you need about 5 units, and we'll say, okay, every time you eat, you got to take 5 units. And so that's easy to do. It's not always precise. Another way that people will end up doing it is learning how to count their carbohydrates. Carbohydrates really determine how much insulin you're going to need. So you end up with a ratio of carbohydrates. And so maybe for every 10 grams of carbohydrate, I need 1 unit of insulin. So that would be my carb ratio. And so I have to learn how to count or estimate the amount of carbohydrates in a given meal that I'm going to eat, and then I decide how much to take. The other aspect is what's called a sliding scale or a correction factor. And this also applies to the short-acting insulin. And that would be not so much related to food per se, but if my sugar is high and I'm not eating anything, but I want it to come down to normal, what do? I can't really use that basal insulin because it's just kind of slow and in the background. So it's not going to do that, with any, it's not an efficient tool for that problem. So the short-acting insulin, the Humalog, the Novolog, we would use a sliding scale or a correction factor. A sliding scale would be like if my blood sugar gets over 150, let's say 150 to 200, if it's in that range, I'll give 2 units. If it's 200 to 250, I'll give 4 units, and so on and so forth. And so you can do that if you're going to eat something. So I'm going to eat a meal. I've determined I need 5 units for what I'm going to eat. My blood sugar is, between 150 and 200. So I'm going to say, oh, that's an extra 2. So I'm going to have 7 units instead of just 5 for this meal, something like that. A correction factor is similar in that it's to say that you need a target blood sugar. So your target is, let's say, 120. And let's say my correction factor is 40. So that means that I think that 1 unit of insulin is going to bring me down 40 points. So if my sugar is 160 and I want to get it back to where it should be, I'll take 1 unit. If it's 200, I'll take 2 units. So something like that. So that, again, that's kind of a general approach with insulin injections. A lot of people, especially type 1 diabetics, use insulin pumps nowadays. The big difference with an insulin pump is that there's just one kind of insulin. It's the short-acting insulin, and it goes into the body in a certain rate, and that becomes the basal rate. And then when you eat something, or if your sugar is high, you get the same thing. You're just not injecting yourself. It's just you're changing how much goes through the pump. The most effective systems that we have these days are what are called automated insulin delivery systems, and that takes advantage of using the pump and the information from a continuous glucose monitor, which is always giving you numbers for your sugar, and that it's using those numbers, and then that's adjusting how much insulin is being delivered. So there is some interaction between those two elements, the insulin delivery and the blood sugar measurement. It's not to the point, we don't have it to the point, February 2026 is where we are now. We don't have it to the point where it's completely hands-off, where you can just let it do its thing and it's an automatic pancreas. You still have to tell it what you're going to eat, But even if you don't tell it what you're going to eat, it actually can do a decent job, much better than it would otherwise. So again, this is just kind of a basic overview of how do we think about using insulin, and generally what kind of approaches are out there. Mostly for type 1 diabetics. Type 2s can use insulin, and sometimes that makes sense. I usually try to limit using insulin in type 2 diabetics because insulin can cause weight gain and more insulin resistance. Even in type 1 diabetics, we don't want to use more insulin than we have to, but we do have to use some insulin, so we're kind of stuck in that regard. But again, these are the conceptual things to be aware of if this is something you're looking at or you're having to deal with.